to the Allied Health Professionals Program of annual academic sessions of Sri Lanka College of Cardiology on today. Sri Lanka College of Cardiology, previously known as Sri Lanka Heart Association, traditionally holds this event for allied health professionals because we appreciate the importance of the role played by all the allied health professionals in this battle against cardiovascular diseases. Unfortunately, we cannot meet physically as we used to do due to COVID pandemic. Therefore, we have adapted to new normal. For the first time, we have more than 1,000 nurses and technicians joining with us today, and we have coordinated almost 40 centers island-wide to have small gatherings to facilitate the weaving of this program at your own hospital. This is a huge project, and today we have connected almost all the cardiology units in the country to join with us. I am happy to say that this year we have lined up important and very interesting topics which we believe will help you in your day-to-day work. Before we begin, let me tell you a few things. Firstly, you can ask questions during the symposia. For online viewers, you can click on the question button and during live streaming and type your questions there. For people who are in physical meeting, you can write the question on a piece of paper and hand over to our coordinator there, and he will type the question for you. Secondly, and importantly also, we have a quiz containing very simple questions based on these lectures, and quiz will be done at the end of the program. During the quiz, but you will have, all of you have to log in with your own devices to choose the correct answer. And please listen carefully because winners will get valuable prizes. Without further ado, let's begin our sessions today, and please enjoy the session. Let me introduce my co-chair today, Dr. Chamara Ratnayaka. He is a consultant cardiologist at Asiri Groups of Hospital. Dear Chamara, please come to the podium.
Very good morning, ladies and gentlemen, and thank you to Dr. Sandamali for introducing me onto the stage as well. And I'm very happy to hear that we have such a huge audience joining us for this very valuable program. So to start off the session, so we're going to start off with the symposium, the title being Nursing Care in a Critical Ill Cardiac Patient. I think it's a very, very important topic for all of us. So to start off the symposium, may I introduce Dr. M. Niraj, Consultant Cardiologist at District General Hospital in Ambilipitia. He'll be talking about triage in the ETU CCU setting. Over to you, Niraj. And may I again tell the audience as well that all our lectures, since this is a virtual meeting, are pre-recorded. So all the consultants who participated have spared all their valuable time to record these lectures beforehand. So let's start off the first talk by Dr. Niraj.
Good morning to all the listeners. I am Dr. Niraj Mahaboob, consultant cardiologist attached to District General Hospital Ambilipitia. My talk today is on triage in emergency department and in coronary care unit. I'll be focusing more on triage in emergency department, as triage is conventionally described in emergency department, but triage basics are applicable to any setting. My objectives are to define triage, role of triage nurse, point of entry process in triage nursing, triage acuity scales, describe emergency severity index, few tips for success at triage, and end the session with a case discussion. Definition of triage. Triage originates from the French word trier, which is used to describe the process of sorting and organizing. Originally, the process was used by the military to sort soldiers wounded in battle for the purpose of establishing treatment priorities. Injured soldiers were sorted by severity of their injuries, ranging from those that were severely injured and deemed not salvageable to those who needed immediate care to those that could safely wait to be treated. The overall goal of sorting was to return as many soldiers to the battlefield as quickly as possible. The purpose of triage is to prioritize incoming patients and to identify those patients who cannot wait to be seen. The experienced triage nurse is able to rapidly and accurately identify the small percentage of patients requiring immediate care. He or she is then challenged to sort the remaining large number of patients who do not require immediate treatment and can wait for physician's evaluation. And also, purpose is to determine the acuity level of the patient, how serious the patient is. Category of triage, in-hospital triage and out-of-hospital triage. Triage is a dynamic process. A person can be triaged anywhere at any time with only a moment's notice. A patient may be triaged in the ambulance bay, hospital parking lot, or on the floor of the waiting area. What do you have to know is triage is not isolated to one location, but rather it's a process. Role of a triage nurse is to identify the sickest patient, so treatment may be provided without a delay. But there are other aspects for a triage nurse. So this is not the only role. The triage nurse has to look after so many other aspects. She or he acts as a greeter, resource person, department coordinator, provides information, controls crowd, crisis manager, ensures the safety and security, infection controller, and communicator and educator. Triage starts with patient arrival. Rapid triage assessment is the beginning to a triage. Then the patient is given a bed and you go through a comprehensive or detailed triage assessment. Then the last component is a critical thinking skill. Rapid triage assessment. Rapid assessment begins with an across-the-room survey, visualizing the patient's appearance as he or she enters the facility is the beginning of the rapid assessment. Great deal of information can be gathered by eyeballing the patient as they step into the waiting room. Does the person use a device to assist with walking? Does the facial expression or body language indicate pain? What's the skin tone and color? Is he or she unresponsive or demonstrating signs of weakness? Is there any limited eye contact? Does the person express fear, anxiety, or agitation? You also have to obtain objective information like ear weight, breathing, circulation, and on disability. Why do we not need a rapid triage assessment? Imagine a scenario in which 10 patients arrive simultaneously to the emergency department. If the triage nurse performs a lengthy assessment on each individual initially, the last patient in line may be the sickest with the highest acuity. So we have to assess each patient for no more than 60 to 90 seconds. Immediate bedding. Immediate bedding is just what it states. During this initial encounter, the nurse must assess 3 criteria to determine the need for immediate bedding, and all 3 must be present. The patient must be obviously ill. There should be a bed available and also a care provider. All 3 must exist. Comprehensive triage assessment. Not all patients will receive a detailed assessment at initial triage. When a bed is available and immediate bedding criteria met, the comprehensive triage will occur at the bedside. Why do you need a comprehensive triage assessment? So that we can accurately determine the final acuity level for the patient. Information obtained during comprehensive triage assessment are vital signs on weight and height. You have to go through a complete history, medication history, and allergy history. Critical thinking skill is used every minute in triage as the nurse assesses patients upon their arrival. As healthcare workers, we have to use our senses to gather information. Once the information is gathered, we then critically think, synthesizing the information obtained to determine an accurate acuity level. There are different types of acuity scales: 2-level, 3-level, 4-level, and 5 levels. 2-level is the basic acuity scale system. You categorize patients into emergent and non-emergent. 3 levels: emergent, urgent, and non-urgent. 4, life-threatening, emergent, urgent, non-urgent. 5 level, which is commonly used nowadays, is life-threatening, emergent, urgent, non-urgent, and referred. 5-level triage acuity systems are Canadian triage acuity scales, Australasian triage scale, Manchester triage scale, and emergency severity index. So these are the commonly used 5-level triage acuity systems. Why do we need different levels in triage scale? This is to prioritize the urgency for treatment and to determine how often you have to monitor the patient. Level 1 means it's a life-threatening condition, patient with life-threatening condition. You need continuous monitoring, whereas level 5, you can monitor a patient far and apart. Emergency severity index. This is a 5-level acuity scale used commonly in US. What is shown is an algorithm. So when a patient comes, is patient dying? Yes or no? Yes, the patient is put into life-threatening level. No, then you have to decide whether the patient can wait or not. If the patient cannot wait, then the patient is put into level 2, that is emergent level. If the patient can wait, the patient is sorted into level 3, 4, 5. Then interestingly, then how you categorize afterwards is depending on the number of resources the patient needs. If the patient needs 2 or more resources put into level 3, only 1 resource, level 4, none in level 5. That's the lowest acuity scale. What are resources? Resources are lab investigations, ECG, chest X-ray, CT, MRI, IV fluids, IM drugs, specialty consult, simple procedure, and complex procedure. What are not resources? History, physical examination, point of care testing, medications, oral ones, and the simple wound care. So there are a couple of key concepts. Choose higher acuity when in doubt. Key concept 2, discontinue assessment and transport the patient immediately to the treatment area if immediate care is needed. Do not delay treatment to finish the assessment. Few tips for success at triage: obtain as much clinical education, communication, and also reflection. We'll go through a case quickly. A 76-year-old male is brought to the emergency department because of severe abdominal pain. He tells you, it feels like someone is ripping me apart. That is, someone is tearing me apart. The pain began about 30 minutes prior to admission, and he rates the intensity as 10 out of 10. That is the highest pain. He has hypertension, for which he takes a diuretic. No allergies. The patient is sitting in a wheelchair, moaning in pain. His skin is cold and diaphoretic. Vital signs: heart rate 120 beats per minute, blood pressure is 88/68, respiratory rate 24, and saturation is 94. What level in acuity scale will you place this patient? So the patient is presenting with signs of shock, hypotensive, tachycardic with decreased peripheral perfusion. He has a history of hypertension and is presenting with signs and symptoms that could be attributed to a dissecting aortic abdominal aneurysm. He needs immediate IV access, aggressive fluid resuscitation, and perhaps blood prior to surgery. So he will be placed in the level 1 category in the emergency severity index scoring system. This requires immediate life-saving intervention. Remember that effective triage gets the patient to the right place at the right time with the right care provider. These are my references, and thank you.
Thank you very much, Niraj, for that very comprehensive account on triage in the ETU setting. May I ask Dr. Sandamali to introduce our next lecture?
Thank you, Chamara. Our next lecture, which is also a very important topic, it's about supporting breathing in a critically ill cardiac patient. It will be done by Dr. Nimangi Mitra Ratna. She's